Hello, I'm Dr. Ken Landa. Thanks for watching. Let's talk about fibromyalgia. This is chronic, widespread musculoskeletal pain, tenderness. It's common, it's underreported, underdiagnosed. It's a primary pain syndrome, but it also is associated with some neuropsychiatric symptoms, symptoms of fatigue and unrefreshing sleep and cognitive dysfunction and anxiety and depression. And it seems to go along with a variety of other relatively common pain syndromes. So it's associated with chronic fatigue syndrome. In fact, some people argue that chronic fatigue syndrome and fibromyalgia are really just different names for the same condition. Also included are temporomandibular joint dysfunction, chronic headaches, irritable bowel syndrome, functional cystitis, interstitial cystitis, the painful bladder syndrome, painful pelvic syndrome. People say there are really no specific boundaries between any of those conditions, between chronic headaches and irritable bowel and fibromyalgia, chronic fatigue syndrome. And interestingly, it all depends on the kind of doctor that you see, what kind of diagnosis you receive. So if you see a neurologist or pain specialist, they're going to say you have a dysfunction of the muscle and the connective tissue. Go see a rheumatologist, going to be diagnosed with central pain sensitization, just a heightened response in the central nervous system in the absence of any abnormality in the muscle or the connective tissue or the joint. See a psychiatrist, get the diagnosis of anxiety or depression. See a specialist in somatic medicine, get the diagnosis of a somatic disorder. That's all with the same kind of symptoms. And it's important because the conditions associated with negative consequences for your ability to function in society, your physical health, it's going to last for typically several years, oftentimes many years, can be debilitating, can be costly, there's lost productivity. See the doctor on a frequent basis, often see the doctor more often than some people with diabetes and with hypertension. Well, didn't even arrive at a diagnosis until 1990. In 1990, they at least defined the condition. They said it's abnormality in the fibrous tissue, it's myalgia or muscular pain. American College of Rheumatology said it's a functional somatic disorder, but the doctors in EULAR, that's the European League Against Rheumatism, which is basically the same thing as the ACR, American College of Rheumatology, except in Europe, they said it's a neurobiological disease. The International Classification of Disease, that's World Health Organization, says it's a somatic disorder. Well, people have divided the condition into 4 different groups. Some people say that, well, you can have a group of people who principally have pain without any associated psychiatric condition because of some abnormality in the serotonin metabolism. And then we have another group that has fibromyalgia with some related psychiatric condition, typically depression. Or you could have depression with the fibromyalgia, just the opposite. Or you could have fibromyalgia due to somatization, and they all receive some different kind of therapies. People argue about the cause. Is it a psychiatric condition? Is it from central pain sensitization? We don't really know at the present time. We don't have any specific diagnosis. We don't have any specific diagnostic tests. We don't have any specific blood tests or X-ray tests. The history of the condition goes way back to the 18th century, and the same players who were prominent in the development of the concept of chronic fatigue were often also associated with the development of fibromyalgia. So we have William Balfour, the surgeon. He said it's an abnormality of sleep and fatigue and stiffness and pain. We had George Baird. He was the neurologist in New York City. He said it's neurasthenia. That was very popular in those days. Said it's fatigue and widespread pain. And anhedonia, lack of enjoyment. Gower used the term fibrositis in 1904. Then in the late 1970s, early 1980s, the concept of fibromyalgia. So fibrositis meant inflammation of the fibrous tissue, but there wasn't any inflammation. That's why fibromyalgia, just myalgia, pain in the connective tissue, pain in the fibrous tissue, that came into being. Journal of the American Medical Association, 1987, said it's very controversial. First criteria American College of Rheumatology, 1990, they came up with a diagnosis, but it was kind of peculiar. And as a matter of fact, one of the lead authors on the paper from 1990, well, he came out in 2008 and said it's clearly not really a disease, but it's a physical response to depression and to stress. And in 2013, he said it's got some of the physical symptoms and some of the psychological symptoms, and they exist on a continuum. Well, the condition is pretty common. So it's been diagnosed in about 2% of the population, some studies 2 to 4% of the population, and if you look in the clinic, in people who have other rheumatologic disorders, say have lupus or rheumatoid arthritis, might be as high as 15% of those individuals. Culture has a lot to do with it, so some people don't go to see doctors or some people keep private. If we look at the sex distribution, overall, seems to be much more common in women, about 9 to men, 1. On the other hand, if we look at those people who seek medical care, seems that women are still much more common, 2 to 3 times more common than men. Age of onset, sometime between about age 20 and 55, can be diagnosed in adolescents, probably about the same amount as adults. And unlike the chronic fatigue syndrome, fibromyalgia seems to run equally through all the different socioeconomic groups. Estimated number of people in the United States, 4 million with fibromyalgia, but according to the National Fibromyalgia Association, it might be approaching 10 million. Clinical presentation, patients go to the doctor and they complain that they have pain all over. It's widespread, it's multiple different sites, it's above the waist, below the waist, it's on the right side, it's on the left side, it's in the axial skeleton, it's in the neck and the chest and the back, it's poorly defined, poorly localized, difficult to ignore the pain, it's severely intense, and oftentimes it's associated with a decrease in a person's ability to function. So it could be so bad that the person continues to drop their keys or drop a coffee cup. Not only do you have to have the pain, but the pain has to be present most of the day, and it has to be present most of the days for at least 3 months. Now, the pain is associated with tenderness and increased evoked pain sensitivity. So if you put a blood pressure cuff on people, they complain of pain. If you just roll your finger on their skin, they complain of pain. We have tender points. And tender points means put the thumbnail and push down enough so that the thumbnail blanches. Well, according to the original diagnosis, the American College of Rheumatology, you had to have at least 11 of 18 particular sites that were painful. Now, in practice, diagnosing pressure-related pain, that's kind of difficult to do. So more recently, they've eliminated the use of the trigger points. They focus on clinical symptoms instead. Widespread pain, multiple site pain, the neuropsychological symptoms. These are the criteria that are now used. But it's changed the prevalence and it's changed the sex incidence. Now, if we look at the peripheral pain generators, what people might have that seems to trigger the problem. Well, in some people it might be from arthritis or bursitis or tendinitis or some neuropathies, some degenerative disorders. Sometimes it might be due to scoliosis, might even be due to joint hypermobility. People can complain of the fibromyalgia because it was triggered by an infection or a metabolic disease or psychiatric issue. Pain initially can be localized to the neck or to the shoulders, but most of the people complain of muscular pain, but some do complain of joint pain. They have pain and stiffness and fatigue, seem to get worse with exercise or unaccustomed activity that causes them to have post-exertional fatigue. They're fatigued when they wake up in the morning. They're fatigued if they have some inactivity. So they can get some stiffness in the middle of the day, middle of the afternoon. Minor activities seem to make the pain worse. They have unrefreshing sleep, even though they sleep for 8 to 10 hours a night. And additionally, they have a group of neuropsychological symptoms. And they might have greater impact even than the pain. So these would be the fatigue and the stiffness and the sleep disturbance, difficult falling asleep, difficulty staying asleep, wake up early, cognitive dysfunction, anxiety and depression. Lifetime diagnosis, about 80%. Find that there are cognitive issues in these people. They have difficult time maintaining attention or concentration, difficult time retrieving words. Short-term memory seems not to be as good as normal. Inability to multitask. Sometimes there's cognitive overload, but the speed of processing seems to be relatively normal. Psychological problems, well, it seems that the issues in the person's life might seem to at least exacerbate, if not cause, the symptoms. So some underlying stressor, that can't be addressed if you're fighting with your spouse or if the kids are having problems, can't be addressed with medicines. And then we have a series of those other conditions that are associated with fibromyalgia. So some people complaining of the headache, either migraine headache or tension headache, or abdominal pain or bloating or dizziness, or sometimes the gastroesophageal reflux or heartburn, sometimes numbness and tingling in the extremities, called paresthesia, sometimes numbness in the skin that's not limited to a dermatome. So we don't have any good idea why the individuals are having this kind of problem. Sensitivity to light and to noise and to temperature. Some people complain of palpitations and even muscle twitching and dry eyes. And some people complain of shortness of breath, dyspnea, dysphagia, difficulty swallowing, low blood sugar or arthritis. Sometimes they meet the criteria for restless leg syndrome or sleep-disordered breathing, obstructive sleep apnea. Well, in order to gain a handle on the condition, the widespread pain index, which is a questionnaire, was created. And it asks, in the past week, of 19 different sites, how many of the sites have you had pain in? So the scale rates from 0 to 19. And they also have the symptom severity scale score. That looks at 4 different areas. Looks at fatigue and whether you wake unrefreshed or not, whether you have cognitive symptoms, whether you have somatic symptoms. And it rates each of those on a scale of 0 to 3. So that means the severity scale score can rate anywhere between a 0 and a 12. Well, how do we diagnose the condition of fibromyalgia? It's pain that you have at multiple sites for at least 3 months, oftentimes associated with fatigue and sleep problem and cognitive problems. The pain is generalized or sometimes can be localized, but that probably isn't good to make the diagnosis if it's just localized pain like low back pain or neck pain. Some people complain of that fibrofog, the cognitive disorder. Then we have to throw in all of those other symptoms that I mentioned, the headache, the abdominal pain, the bloating, the jaw pain, the dizziness, and the paresthesias. That's how the diagnosis is arrived at. Well, that 1990 conversation at the American College of Rheumatology said you had to have widespread pain. Had to be above the waist, below the waist. Had to have at least 11 of the 18 trigger points, and it omitted all of those other symptoms. Omitted all the other symptoms that we've talked about. They were exclusive of the diagnosis. Well, then in 2010, they got together again and changed the definition of the condition. They dropped the tender points, so now you don't have to have the tender points. And what they said is you could have those somatic symptoms, and the somatic symptoms were actually very important. And then they relied on that widespread pain index and the symptom severity scale score. And that'll be enough to drive you nuts. It's like the old-fashioned Chinese restaurants where you have to have a certain number of these symptoms and a certain number of those symptoms. So you had the diagnosis of fibromyalgia if you had the widespread pain index score of at least 7 and the symptom severity score of at least 5, or You could have the widespread pain index that was from 3 to 6 and the symptom severity score of 9. And I'll tell you, that's just not the way you make a medical diagnosis. So then they came out in 2011 and they said, well, we're going to have the patient self-report score. And then in 2016, they added general pain in at least 4 or 5 regions so that it couldn't be localized or a regional pain. It had to be a generalized pain. Then what we had was in 2018, the American Pain Society and a public-private partnership got together and they diagnosed the condition when you had at least pain in 6 different sites of 9 that were listed. You had moderate sleep problems, you had problem with fatigue, you had all this for at least 3 months. And on thorough examination of the soft tissue, examination of the joints, you look for things like osteoarthritis, rheumatoid arthritis, lupus, rarely find them. Palpate the soft tissues, the muscles, the ligaments, the tendons, the joints, to assess for synovitis and inflammation, rarely find. Also check to see if there's any indication for a neurologic examination. Person's having those paresthesias. The laboratory workup is relatively simple. A blood count, a urinalysis, metabolic panel, check the thyroid, check some of the inflammatory markers like the SED rate or C-reactive protein. American College of Rheumatology now says you don't have to do a lot of tests. Don't do the standard rheumatologic tests. Don't check the rheumatoid factor. Don't check an ANA. Don't check any of those. But you could test if the person looks like they're having obstructive sleep apnea, check for that. Psychiatric abnormality, if they have anxiety or depression, have them checked for that. If they have the paresthesias that are unaccounted for, that might be sign of nerve disorder, do a neurologic examination. The differential diagnosis is really quite broad. It ranges from polymyalgia rheumatica to inflammatory arthritis and rheumatoid arthritis and psoriatic arthritis and lupus and infection with HIV or hepatitis C or Epstein-Barr virus or degenerative joint disease or bursitis or tendonitis, repetitive strain injuries, people with hyperactive thyroid, hypoactive thyroid, people who have abnormalities of the parathyroid gland, people with depression, people with anxiety, people who are taking the statins frequently develop a condition with the muscles, and so too with the aromatase inhibitors that are very commonly used in women who have had a history of breast cancer. Celiac disease can cause the problem, myasthenia gravis, neurology problems, peripheral neuropathy, TMJ, endometriosis, chronic fatigue syndrome, all have to be considered. So there's a broad overlap of all of these kind of chronic pain disorders, the irritable bowel syndrome, and chronic fatigue syndrome, and interstitial cystitis, temporomandibular joint, and migraine headache. Well, when it comes to finding out what the underlying problem is, we just don't know. Now, there are a lot of ideas about what the problem might be, but those problems are, at least at present, not ready for prime time. So some people think it's an abnormality in the central pain processing. So something is wrong with either the way the brain handles the pain, amplifies the pain, or maybe it's got to do with a decrease in the pain inhibition. Maybe it has to do with some sort of abnormality of the cytokines or the serotonin. Maybe it has to do with insulin-like growth hormone. Maybe it has to do with glutamate or substance P or dopamine or serotonin. All of those are ideas. None of them have really proven out in the long run. Well, we still don't even know why it tends to affect women more so than men. Some people say it's because of more anxiety or more depression, maybe changed behavioral response, maybe a genetic proclivity. We know that there's increased vulnerability with 50% of identical twins may have the same condition. But that doesn't necessarily mean that it's the condition that's being heritable. It might be some sort of an abnormality in the metabolism of serotonin or dopamine or the catecholamines that's passed on. We just don't know. How do we treat people? Well, our goal is to improve their physiology, their mental state, their social domains. We try to modify those things that can be modified: stress management, sleep hygiene, balanced diet, weight reduction, graded exercise. All of those obviously very important. And continuing on with the non-medicinal therapies, we like people to have a supervised and graded exercise program, sometimes cognitive behavioral interventions, a lot of explaining about the genetics and the trigger and the education with regard to stress and how it can affect the condition. We discourage illness behavior. All of that obviously important. Some people find relief with yoga or tai chi or hydrotherapy. But at least at the present time, it would appear probably the best is exercise. And EULAR, the European League Against Rheumatism, 2017, they came out and said the only therapy they strongly recommend is exercise. Exercise could be water aerobics, could be on a bicycle, but do it for about 30 minutes, a couple times, 2 times, 3 times a week, adhere, and then increase, and that seems to be quite helpful. The patients, on the other hand, say, hey, that's going to make me poop. I don't want to go and do that. So graded exercise. Well, there have been 3 drugs that have been approved for therapy: Lyrica and Cymbalta and Savella. Savella has been approved, but it's not yet on the market at the present time. Now, it's interesting that the Savella is an SNRI. It's sort of like Cymbalta. And unlike tramadol, it's very frequently used, tramadol is a mu-opioid receptor agonist. So it's actually acting as a narcotic. But tramadol also is an SNRI. So it seems that the reason tramadol works, if it does, in fibromyalgia is not because of the pain-reducing ability through the opioid receptor, but rather through the SNRI, the antidepressant activity. Now, it seems that people who have fibromyalgia are not going to be improved with aspirin or strong opioids or sedatives or herbal therapies or homeopathy, dietary supplements. 90% are using some sort of complementary and alternative therapy. The tramadol, as I mentioned, probably not a good idea to use. Sometimes people can find improvement with the TENS unit or sedating antidepressants like amitriptyline or other tricyclic antidepressants, or even Flexeril for a few weeks. Acupuncture seems to work in some people. Chiropractic really doesn't seem to work for this condition. Person who has the fibromyalgia going to take some time to find the best kind of therapy. If we look at tertiary referral centers, the big universities, well, the patients who seek care at those institutions, they don't seem to fare very well. So over a period of about 8 years, there really doesn't seem to be much change in either the pain or the fatigue or the anxiety or the depression or the sleep disturbances. But yet, people who are seeing the family doctors seem to do better. Better probably because they're less severely ill in the first place. So that's the story about fibromyalgia. In spite of considerable investigation, we still lack understanding of the condition. It seems that it's the result of multiple factors that we really don't understand. At least at the present time, it's thought to be an abnormality in the central pain processing. But whether it's the same thing as or different than chronic fatigue syndrome, that remains an issue. We have lots of treatments, but none of them seem to work. Best, as far as therapy is concerned, is to find a doctor who's a caring doctor, get some stress reduction, have graded exercise, and one day we'll probably understand what fibromyalgia is all about. But at least at the present time, our knowledge of the condition is not much different than it was 100 years ago. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.